and she was started on hemodialysis for volume optimization at a creatinine of 4 mg per deciliter. So at presentation to our hospital, her blood pressure was 200 by 110 millimeters of mercury. She did not have differential BP recordings. She was significantly orthopnic. Pulse rate was 90 and regular. There was no renal artery injury. Her systemic examination revealed bilateral decreased vesicular blood sounds. No definite cardiac murmur was auscultated. She did not have any evidence of significant musculoskeletal disease. Because of query acute gout, we examined the same and there were no positive findings. So the clinical syndrome was one of a resistant hypertension, uncontrolled, requiring more than 5 drugs, history of recurrent flash pulmonary edema, and a progressive renal failure which was unexplained in this patient. Her urine examination did not reveal any proteinuria or any active urine sediments. So provisional diagnosis of renovascular hypertension with chronic kidney disease was kept with a pathological diagnosis of renal artery stenosis with ischemic nephropathy. Differentials for renal artery stenosis etiology, first being atherosclerotic renal artery stenosis, second being Takayasu arthritis, and third being fibromuscular dysplasia. So in view of her age and clinical presentation, with no clinical systemic findings suggestive of differential pulselessness, which to suggest Takayasu, we kept atherosclerotic before Takayasu arthritis. We went ahead with investigations. So radiology revealed asymmetric kidneys. Her right kidney was 9 centimeters, her left kidney was shrunken, it was only 5.8 centimeters. Went ahead with the renal artery Doppler, which significantly revealed that there was a power stardust pattern which was noted in the right kidney. The left kidney was shrunken and hence the vascularity could not be assessed. So the significance of doing a Doppler is that the normal resistance indices which we obtain should be less than 0.6. So elevated resistance indices, especially in the proximal branches of the renal artery, signify that there may be a significant stenosis. These are pictures taken for reference. This is the normal renal artery waveform which shows a peak systolic velocity, an acceleration drive, and then a fall, and an end diastolic waveform. These are pictures from our patient which reveal that the acceleration peak itself is blunted, which is a Powers waveform, and there is a slow deceleration which is known as the TARDIS pattern. We went ahead with the CT renal angiogram. We faced a few dilemmas which I'll mention in the next slide. So these are the positive findings on the CT renal angio. Single right renal artery with total occlusion of the osteoproximal segment but reformed patent distal renal artery. She also had an occluded osteoproximal segment of the left renal artery with reformed patent distal left renal artery. Both kidneys show poor contrast enhancement and poor excretion of the contrast. In addition, some surprising findings here. Occluded celiac artery ostium with distal reformation and severe stenosis in the inferior mesenteric artery with distal reformation. So she had significant osteal disease in the descending aorta, abdominal aorta, with significant bilateral renal artery stenosis as well as celiac artery and inferior mesenteric trunk stenosis. This is the 3D reconstruction of the CT angio. I would like you to focus on this side here with significant cutoff which is seen right distal to the ostium of the right renal artery. So we faced multiple dilemmas in the management of this case. First, clinically euvolemic patient who was going in for recurrent pulmonary edema. We did have a background of rheumatic heart disease, but it was not significant enough to cause such a clinical presentation. Etiology of renal artery stenosis in a female, no obvious risk factors for atherosclerosis, no clinical findings suggestive of Takayasu arthritis, creatinine decline on steroid dosing and elevation on steroid tapering. So we did try to taper the steroids that she had been started on. We found that every time we tapered the dose, her creatinine would go up. Every time we started some low dose, her creatinine would come down. However, it was not correlating with the clinical picture. She had fluctuating urine output as well, which may be secondary to the significant renal artery stenosis. Now, her left kidney was shrunken 5.8, so we assume it's a non-functioning kidney. So in a solitary functioning kidney, should you go ahead with contrast imaging? How do you come up with the diagnosis and how do you go ahead with management? So she had recent progression to advanced renal failure So whether to do a contrast imaging or not was also a question, and whether we should intervene in such an advanced case to provide relief of pulmonary edema. In our patient, she needed alternate day dialysis in view of significant orthopnea and pulmonary edema. After about 2 weeks of intensifying dialysis, her volume status was optimized. BP was controlled with 5 drugs. Steroids were tapered and stopped because there was no definite evidence and indication for the same. Cardiology opinion was sought. She was started on aspirin and statins. Intervention was deferred in view of lack of definite benefit in an advanced renal failure and total occlusion with patent collaterals. So the lessons we learned, this was a case of resistant hypertension. How do we define resistant hypertension? An office BP of more than 130 by 80 millimeters of mercury, despite the use of 3 antihypertensives from different classes, including at least 1 diuretic in maximally tolerated doses. So important to exclude pseudo-resistance, which may be because of improper dosing, non-adherence to drugs, or even whiteboard hypertension. Around 10 to 15% of all hypertension is resistant, with risk factors mainly being elderly, obesity, chronic kidney disease, and diabetes. Significance of knowing resistant hypertension is that it is associated with high risk of adverse cardiovascular events and mortality. On the right hand side, we have definitions. So beyond resistant hypertension, there is also something called a refractory hypertension, where there is use of at least more than 5 medicines for control of hypertension. When should one suspect secondary hypertension? If the onset is very early, less than 30 or above 50 years of age, when one has resistant hypertension, unexplained hypokalemia, presence of end organ damage at presentation like hypertensive retinopathy, LVH or stroke, differential BP recordings, features suggestive of pheochromocytoma, obstructive sleep apnea or Cushing syndrome, and when there is history of drugs or medication intake such as steroids, oral contraceptive pills, NSAIDs or herbal medication intake. When we look at the causes of secondary hypertension, the predominant cause is renal. So about 70 to 80% of secondary hypertension is because of renal cause. Among the renal causes, about 90% is because of renal parenchymal disease. So most common cause of secondary hypertension is renal parenchymal disease. Among 10% of cases will have renovascular disease. 5 to 10% of the remaining causes would be endocrine, such as pheochromocytoma, Cushing syndrome. 2 to 5%, which is actually on the rising incidence, is obstructive sleep apnea, and less than 1% of causes of secondary hypertension would be drugs or herbal medication intake. When do we suspect renal artery stenosis? So difficult to control hypertension, asymmetric kidneys, which means the difference between the size of both kidneys is more than 1.5 centimeter, acute rise in creatinine after starting an ACE inhibitor or ARB, presence of triple vessel disease, any vascular disease in any other organ bed can suggest that there might be presence of renal artery stenosis, unexplained renal dysfunction or renal failure with uncontrolled hypertension, significant changes in creatinine with change in volume status, and a syndrome called Pickering syndrome, which is uncontrolled hypertension with recurrent flash pulmonary edema with refractory heart failure, which is what our patient presented with. So when we look at therapeutic goals, it's mainly blood pressure control, glycemic control, all the modifiable factors to prevent progression of the disease, preserving renal function and reduction of cardiovascular morbidity. What is the importance of early intervention? Routine revascularization, be it percutaneous or surgical, is not recommended in atherosclerotic renal artery stenosis due to lack of evidence of benefit over medical therapy. So they say medical therapy is as good as intervening surgically or percutaneously. However, the European Society recommends revascularization in such cases with pulmonary edema or refractory heart failure. So balloon angioplasty with or without stenting is recommended. We should always weigh the risk versus benefit. In our patient, because she had almost total occlusion of the ostium with advanced kidney disease, the risk of the procedure weighed much more than the benefit for this patient. So there can be risk of renal artery dissection as well. So who are the ideal candidates for revascularization? BP not controlled on medical therapy, recurrent pulmonary edema, unexplained renal function decline, which is of short duration, and short duration of BP elevation prior to the diagnosis of renal artery stenosis, which means the process is fairly recent and there may be amenable to therapy. So evidence to support BP control is definitely there with procedure, but there is no definite benefit on mortality or even preservation of renal function. So it is associated with poor long-term outcomes. CKD resulting from renal artery stenosis is termed as ischemic nephropathy, where there is reduction of GFR due to diminished renal blood flow. Usually results from high-grade stenosis, which is more than 80%, and vascular occlusion mainly leads to hypoxia, inflammation, fibrosis, and chronic injury. Thank you.
Thank you, Dr. Rachna.
A few clarifications. This patient was following up in another major hospital in Coimbatore, and she was initiated for dialysis in that hospital. They have given already 4 sittings of dialysis, and they said she may not recover. So patient was very much worried, and she was related to one of the neurologists in Salem, basically they're from Salem. So he referred the patient to me, so see whether any chance of recovery. So mainly for that purpose they came, and we tried to manage her conservatively because the starting grade was only 4, and earlier it was only 2.2. It was a very short history, but the problem was she went for recurrent pulmonary edema. So we are not able to withhold the dialysis because of the pulmonary edema. And right from the beginning, after the initial ultrasound itself, we had made a suspicion of renal artery stenosis, but we could not even do renal Doppler because of the pulmonary congestion. So twice we attempted, and Tirunakurasu could not do it. So we have to intensively dialyze her 2-3 days regularly, and then we did a Doppler, which was suggestive of that. Next dilemma was whether to go for a renal angiogram, because it is going to worsen the renal parameter further, and she may not recover her renal function at all. So we had discussion with the family, and finally we decided we will better have a diagnosis and if possible anything to treat. So we went ahead with CT renal angiogram, which showed one side totally occluded. We discussed with Dr. Balaji and Dr. Vishnu also, and finally with elaborate discussion, we decided not to proceed further, like going for a angioplasty stenting, because overall benefit was not there. So patient is on now regular dialysis at Salem.
Few the questions. I remember reading articles on whether whether to intervene renal artery stenosis or not. It's itself a debate whether to give medical therapy or revascularization. I have few thoughts. Cardiology part, is it really a rheumatic heart disease? Because you said in the presentation with a heart rate of 90, with a moderate MSMR, we are not able to find a murmur. One. Number two, the creatinine decreases when you give steroids. It increases when the patient is tapering on steroids. I saw just like that. 2. Number 3, this patient is progressively having an end organ damage in the form of renal disease, recovering dialysis, already on dialysis, and although there is a rheumatic heart, although there is a valvular mitral disease, likely to have a progressive vascular disease, and also she has mesenteric vascular disease. A few thoughts. Even since the patient is already on dialysis, could the benefit of the angioplasty would have helped her in terms of recovering the opposite kidney function? One. Number 2, is there any the underlying CTD in this patient? Because CTD or vasculitis, because the steroids part is.
She was started on the steroid.
My last question is, can be an late onset FMD because being a female?
Total occlusion, and only in the ostium. FMD is ruled out. She was started on steroid by the other nephrologist. He also would have thought in the same way whether anything is possible. Takayasu was the thing which was very much in our mind because of the renal artery stenosis, and because he is seen by another senior nephrologist only. So he only started on steroid, but there was no clear-cut description in his notes or anything like why he started steroid. Maybe gout or something like that. Patient was telling it was because of the pain it was started. But after steroid, there was some slight improvement, but she was put on dialysis. So we continued steroid, and we want to remove her or take her away from the dialysis. But then after that we were not able to do it. So we thought steroid not necessary because repeated urine analysis, even urine eosinophil and other thing we did, everything was normal. So we thought we'll withdraw steroid. But when we tried to reduce steroid, symptoms were little even worse, whether it was just correlated. That all matter of 1 or 2 days. So again, we have to take her for dialysis. In renal artery evaluation, we said we will go ahead with dialysis, do all other investigation. Procedure, yes, it may or may not. But the problem is, most of the time we have seen so many renal artery stenosis, we have done a correction. What we find is initially the BP control is very good. 5 drugs, it comes to 3 drugs or even 2 drugs, they become better. But again, 3 to 4 years later, we find slowly their anti-epilepsy dose is increased. Early in the disease, if you have done it, yes, renal function would have been preserved. But this case already it has reached almost near end stage renal disease. Again doing the procedure, again angio, again other things, whatever residual renal function is there, even if you put a stent, would have gone because of the contrast and other procedures.
The cause for other vascular stenosis?
I just have a few points to add. Fibromuscular dysplasia predominantly.
No, I agree with that. Just a thought because we don't entertain that here because opposite side is not open.
Predominantly affects mid to distal renal artery, does not affect the proximal.
And also age is little high.
And because she had concomitant additional disease in the celiac and inferior mesenteric, it's more likely to be atherosclerotic in etiology. With the steroids, initially we thought it may be Takayasu because female presented with renal artery stenosis with no other obvious risk factors for atherosclerosis. Rheumatic heart disease is not usually associated with an added risk of atherosclerosis. It looked more like atherosclerosis right from the beginning, but clinically she did not have pulselessness, she did not have fever, her inflammatory markers were not elevated. Clinical picture did not support Takayasu.
And she is not fitting into the criteria of Takayasu.
Yes, so clinically that was deferred. Then the next thing is intervention. Now, for the shrunken kidney, no intervention is going to help. The only benefit which she may have gained from intervention is BP control and reduced incidence of pulmonary edema.
Yes, so that's
which we were able to control with intensification of dialysis, and her blood pressure also was controlled with the drugs that we were giving. So we decided, okay, the risk of procedure may be higher in this patient, and if we do intervene for renal artery, what do we do for the celiac artery and the inferior mesenteric? So the decision to take her up on medical therapy was taken.
okay. So, sir, you have a comment? Yeah.
I happened to attend a meeting on vascular event at Sydney, and a case was presented with renal artery stenosis. It was treated with coil stenting. Even after treating the addressing the vascular supply, the hypertension persisted.
Yes, it is.
And I brought my own auntie to Chedian, who demonstrated renal artery stenosis by auscultating. We have read in the textbooks about the bruit. I heard the bruit only in my auntie. Chedian only picked it up. And we never did any stenting. One thing. And she said, no atherosclerotic risk factors. Hypertension itself is a great risk factor. It will beat between the endothelial cells, lift it up, and fat will go in. So how can you say no?
Oh, no.
I meant diabetes and dyslipidemia. In this patient, I feel, sir, hypertension is secondary to renal artery stenosis. Because right from the beginning of diagnosis of hypertension, she required more than 3 drugs.
So one can always argue hypertension is the effect, not the cause. So either way it can go.
Hen or egg first?
The other point to you is it is a known phenomenon that even under intervention hypertension can persist in the renal artery mechanics. Thank you, sir. And next presentation is going to be from Dr. Madhushankar. Let us listen what is his misfortune over his case.
Good morning, everyone. Catchy title that I hear. But we should also remember that a wise man can never cross the same river twice, and so does a light never strikes the same place twice. And why I meant this, we'll get to know it again. So this is a 65-year-old lady who's a diabetic for almost a decade. Recently, she was on antihypertensives, hypothyroid, and she presented to gastro department with poor appetite and abdominal discomfort. When she was incidentally detected to have a creatinine of 4.7. The creatinine roughly around 4 months ago was normal. So from gastro, she was referred to us for further management, and this happened way back in June 2020 during the time of COVID. And the next day her creatinine, which we repeated, was 5.6. So we made a diagnosis of acute kidney injury, which is a rapidly progressive renal failure. She was on clopidogrel as a preventive measures, which might help to facilitate biopsy should it be. So the treatment, the discussion part is an acute kidney injury is when the dysfunction occurs within hours to days and it is potentially reversible. It was classified as rifle in the past, but then it was shrunken and it is now classified into stage 1, 2, and 3 based on serum creatinine and urine output. The numbers in the urine output are quite confusing, so we will remember the creatinine. If you know the baseline and if the increase is around the 2 times from the baseline, it is stage 1, 2 to 3 times would be stage 2, and anything beyond 3 times of baseline or an absolute creatinine of more than 4, or if someone is on renal replacement therapy, that would be called as stage 3 acute kidney injury. To evaluate, we know it would be either a pre-renal, intrinsic renal, or a post-renal. All that we require basically is an ultrasound and a urine routine. An obstructive is post-renal, where an obstruction can be at or beyond the level of renal pelvis. It can occur unilaterally or bilaterally. It can be an extrinsic compression like a lymph node or an intrinsic compression inside the lumen of the ureter because of a stone or a sloughed papilla. Now, an ultrasound will show a dilatation of the collecting system. Depending upon the site and the severity of obstruction, it can be a hydronephrosis or a hydroureteronephrosis. If there is an obstruction at or below the level of neck of the bladder, you will have a bilateral dilated system. Neurogenic bladder or a prostate enlargement or a posterior urethral valve in the children are the likely causes. Meatal stenosis is theoretically, but very rare. The simple thing to relieve a bilateral an obstruction at or below the level of the neck of the bladder is a Foley's that sort of decompresses the system, and then the creatinine starts coming. Now, a few takeaway here is, can a system be obstructed but still there is no dilatation? It's possible when we image too early, when we have not given adequate time for the system to dilate, or when the ureter is encased, it doesn't have adequate space to dilate as in retroperitoneal fibrosis or radiation, or when there is a simultaneous renal involvement so much so that there is no urine production. Sometimes ultrasound may not be able to pick up a dilatation. Now, in pregnancy, due to the effect of progesterone, and in diabetes for a long duration where there is increased urine flow for a long years together, the system can be dilated without any obstruction. Now, coming to intrinsic, this is pre-renal cause of acute kidney injury, where the supply to the kidney is the renal supply or the blood supply to the kidney is compromised. It can be an absolute hypovolemia, where there is a volume loss because of loose stools or trauma, blood loss, whatever. An apparent hypovolemia is when the volume is adequate but the kidneys are not receiving adequate blood supply, as in metabolic acidosis where the vasculature is dilated, as in shock, or as in cardiorenal syndrome where the pumping is not sufficient. Now, coming to intrinsic renal, this is the area of interest today. It can be a renovascular, as we just discussed. It can be glomerular or interstitial. Now, the simple way to differentiate, the post-renal, we know, we do an imaging, we will get the obstruction, and then that is how we diagnose. Whereas, how to differentiate between pre-renal or an intrinsic renal pathology, a simple investigation would be an urine routine. In most of the cases, a pre-renal cause, as in dehydration, would be planned. It may have some hyaline cause, some calcium oxalate crystals, but those are not very significant. An intrinsic renal pathology will have an active urine, as in proteinuria, hematuria, or pyuria, which is more exaggerated when the pathology is involving the glomeruli. When it is involving the interstitium, the degree or the severity is less. Now, this is of very importance or a significance, I would say, because as much as 1 in 5 of the admissions inside the hospital can develop an acute kidney injury. And what is shown is that when someone develops an acute kidney injury, even if it is transient, like short lasting, the outcome is worse. It can be an outcome in the ICU or in hospital or after discharge or 90 days on follow-up. If someone requires dialysis, the mortality can increase to the tune of 30 to 60%, which is roughly 2 out of 3 with multi-organ renal dysfunction going under dialysis may not survive. Now, the mortality is more when you compare along with the mortality that arises out of a myocardial infarction or a respiratory distress. Now, drugs are most important causes of acute kidney injury. The set of drugs can increase or they can mimic acute kidney injury or a rise in creatinine without actually increasing the creatinine. That is when they inhibit the secretion of creatinine. Acid-cimetidine, which we no longer use, etc., an antibiotic which is not very commonly used, tyrosine kinase inhibitors, steroids because of their catabolic nature, renin-angiotensin system inhibitors, one of the most commonly used drugs for hypertension, SGLT inhibitors, which is finding its way not as an oral diabetic drug but also in multiple other indications, and calcineurin inhibitors. They can alter the renal hemodynamic and cause acute kidney injury without causing any direct renal pathology per se. And drugs which can affect the kidney and cause acute kidney injury are very commonly used ones like antibiotics, beta-lactam leading the group, proton pump inhibitors, that is the drug which I love the most, or I love to hate it the most. Even H2 blockers are not saints. They can also cause acute kidney injury and acute interstitial disease in this case. Painkillers and novel drugs like these newer biologicals which are widely used in oncology, rheumatology, and those departments, they are also known to cause significant renal dysfunction. It is more common when someone is dehydrated, they are exposed to other nephrotoxins, when the duration of drug that you use is going to be long with a high dose, elderly with a pre-existing renal compromise, or a multi-organ illness. Now that was the discussion teaching part of it. Now coming to the investigations in this case, her ultrasound is normal, urine was active, and it was sterile, there was no culture, so we made a diagnosis of a rapidly progressive glomerulonephritis. Now, her being a diabetic for more than a decade, the primary pathology or the primary diagnosis would always be a diabetic kidney disease, but that is not the case here because the progression was quite rapid. What was normal 4 months ago went into stage 3 in a short duration. So, it is unlikely that a diabetes presents in this manner with an active urine. So, it is a glomerulonephritis. The further flowchart for evaluation of glomerulonephritis would be to do a complement, viral screening, ANA, ANCA, and anti-GBM. Now, that is how, based on this, we classify the glomerulonephritis as complement mediated. Based upon whether it is a classical complement pathway or an alternate complement pathway, we further diagnose it as an infectious or a lupus. Now, IgA and its associated IgA vasculitis are two conditions where complement will be normal, but it is still a complement mediated disease. An ANCA is a quasi-immune disease, and anti-GBM also does not involve complement mediated. So, further her creatinine worsened the next day. Her viral screening C3, C4, ANA, ANCA was non-reactive. Because of the rapidly progressive nature, we pulsed her with methylprednisone, with which the creatinine started coming down and the urine output started going up. And the biopsy showed significant crescents. Now, it was more of a crescentic nature. 12 were cellular and 7 were naked, nascent. There was not much of a cellularity, but there were crescents in those glomeruli with a significant RBC cast and a significant IPTA. IPTA means a chronicity, where being 60 plus, we expect that to have this amount of IPTA. Immunofluorescence showed some deposition. Now, this is the significant crescents. What is crescentic shape with inflammatory infiltrates, and this is the linear glomerular basement membrane staining which we found from the biopsy. Now it is stained 3 plus for IgG and 2 plus for C3C. Now let's forget all the technical things here. Now this is a case of a rapidly progressive glomerulonephritis with the linear basement membrane staining, which is commonly found in either a diabetic kidney disease or an anti-GBM disease. Again, this dilemma comes right from the beginning. Could it be just a diabetic kidney disease or an anti-GBM disease here? The presence of significant crescents more often of a uniform morphology and significant endocapillary absence of hypercellularity, and the way with which she presented makes a diabetic kidney disease unlikely, bringing us to a possibility of anti-GBM. The titers which we sent previously were available simultaneously along with the biopsy. The anti-GBM titer was 113. So in addition to steroids, we started plasma exchange. We have a cyclophosphamide in addition to sugar control and other needs. The diagnosis is an anti-GBM disease, which is very rare, around 1 in a million is like 10 lakhs. It can occur either in the middle-aged group, in a male who is exposed to smoking, or in an elderly, in a female. The problem here is the antibodies are against the basement membrane, which is involving the kidney and the lungs. Now, if you don't diagnose or treat them, almost all of them will end up in dialysis in a short duration. And mortality is also high, roughly 50%. If there is an adequate immunosuppression and disease control, then it is 50%. Otherwise, it is almost 96% as per date. The primary modality is to remove the antibody. Obviously, flux is the treatment of choice for any antibody that has to be removed. Further on, the immunosuppressions will reduce further production of antibodies. So we did flux till the antibody disappeared, and then we gave her cyclophosphamide and steroids. Now, this is where the real risk comes. Around 1/3 of anti-GBM can have ANCA in their system. Such a cases will have more systemic features like fever, musculoskeletal symptoms, joint pain, arthritis, skin manifestations, but they have a good outcome provided you treat them initially aggressively like an anti-GBM and you maintain the treatment like an ANCA vasculitis. Because the treatment for anti-GBM is for a 6 months duration. We don't give a maintenance therapy, just a 6 months. Now, recurrence of anti-GBM is rare. It is mainly because of smoking. If you are planning to transplant a case who was developed in stage because of anti-GBM, it is advised to do, but only after the antibody disappears. In her, after 7 sessions, within 20 days, the antibodies became undetectable, and she was started on steroids. Now, she developed 2 episodes of steroid psychosis requiring admission. So I had to stop steroids and give her reduced to Coimbatore, and cyclophosphamide was given for a 2 months duration. And then significantly, the creatinine settled down to 2.1. She was never dilated during the course of illness. It was managed with plasmapheresis and immunosuppression. Now, she maintained a creatinine around 2 months after the initial diagnosis. Her creatinine was 1.6 and the urine had significantly mellowed down. But subsequently, she was doing well till July 2024 when her creatinine was 1.1. The urine was negative throughout the follow-up, and the ACR had come down. But in July, August last year, her creatinine went up and then it started going up, and the urine which was negative also became active. And then simultaneously, she started developing some joint symptoms. Now again, this is a new onset renal dysfunction in this case, that is Obstructive struck her for the second time. Again, this is a glomerulonephritis. Whether this is a diabetic kidney disease which is slowly progressing, or this is a recurrent anti-GBM, or this is a new disease that is manifesting, we need to look at. We repeated the titers. Now her titers of ANCA, FPO ANCA came positive. We did a biopsy. All that we have to notice in this biopsy is what was the cellular presence previously had become more of a fibrous and fibrocellular presence, and her IPTA had worsened. Although her anti-GBM staining still remained, the intensity had come down. Now, this is where we thought whether it is really an ANCA-associated vasculitis, because there should not be any immune deposits in ANCA vasculitis in the immunofluorescence microscopy. But here it had. So the point here is, if some kidney stains, will it ever disappear? The answer is still ambiguous. There are cases where in transplant scenario, C4d once positive stays positive for the rest of their life. Here there was a reduction in intensity along with multiple crescents of polymorphic change, and the titer was negative. That is when we thought this could be a new onset ANCA-associated vasculitis on a pre-existing anti-GBM disease. In few scenarios, anti-GBM can be negative when the titer is less, or the kidney acts like a sink where it absorbs all the circulating antibody. So for her, we tapered the steroids quickly because we knew that she could develop psychosis with steroids. Because there was significant renal dysfunction, we had to give her on cyclophosphamide. And plan would be to switch her to rituximab because of the age and the risk factors associated with the cyclophosphamide. Now, the diagnosis is occurrence of an anti-GBM and ANCA at different timelines in this patient. So, if she had had some systemic symptoms in the past, if the ANCA was positive before, or if the urine was showing some activity, maybe we could have not done the dual disease back then, but then the titer was clearly negative, and for nearly good 4 years she was retaining normal activity. And that is how I think it is a disease of two different glomerular pathology manifesting at two different time intervals, with a significant 4 years of a normal renal function and a normal urine finding. Right? I think that ends it. Thank you.
Thank you, Madhushankar. Any questions? I have questions. Could it be false positive onca?
Unlikely, because clinically the creatinine progressed. What was normal a month ago started going up, urine became active, so there is definitely a glomerular pathology going on there. And only thing positive was ANCA, and the biopsy also showed progression.
But biopsy was more consistent with GBM.
No, GBM should have a uniform pathology. All the crescents should have a uniform structure. They should be either 100% cellular, or when you miss the diagnosis, they are 100% crescentic. You don't find polymorphic crescents in the anti-GBM disease.
But it's a treated disease.
It is a treated disease, but then in between she was normal. That cannot explain what was happening. I showed you for 4 years her creatinine was between 0.9 to 1.2, which is unlikely. The other, we could argue is it's a diabetic kidney disease.
But you had done a biopsy which was against diabetic kidney disease.
Secondary cell gain nodules are nothing to suggest a diabetic activity going on in the kidney.
There was no lung involvement.
Obviously, I think we have consulted the patient during the first admission.
So a little before, I think I saw Nagaprabhu. Nagaprabhu, can it be false positive onca or still it is? Because of the biopsies.
It might be MPO onca positivity without any significance, because the renal biopsy is against it.
See, there is a renal significance there. You cannot just disregard this as a no significance.
Only on follow-up we will be knowing whether any new symptoms are developing or
The creatinine had come down from
other systems.
Other systems need that or need not be there. It is not essential. She has already been immunosuppressed.
There are points in favor and against, because one can always argue this is because you have proven beyond doubt it's GBM. GBM can, it's okay. It can relapse. It can relapse.
There is no evidence of relapse here.
4-year onchosis vasculitis without involvement of other organ other than kidney is little odd, but patient is on treatment.
It was not positive for 4 years, and the first time it was negative, and it was repeated only now where it was positive. There was no need to repeat the entire interview because she did not have any manifestation of it. Her son is a pediatrician in UK, so obviously any simple symptoms, I'm sure they would have picked it up amongst their conversation.
Okay, so we are fortunate to discuss this with misfortune.
No, I didn't get you.
Okay, so we are fortunate to discuss this misfortune.
We do come across a lot of renal limited disease. For example, so many anti-GBM disease we have seen without any lung involvement. Similarly, we have seen vasculitis limited only to the kidney. We have seen SLE only limited to the kidney. So, kidney biopsy is the final one.
Because when the lung biopsy is not able to give an answer, we always end up doing a renal biopsy. There is no discussion on it. The point is this, but anyway, my last question to you is, why the lightning cannot occur in the same place again and again before Dr. Kathamuthu takes over? Sir, you can load your slides.
It cannot. Yes, a wise man cannot cross the same river twice. Either the river moves away or you grow up. That is not maturity.
Okay, so you can. Thank you. So over to Dr. Kathamuthu to take us to travel on an unobstructed road.
Obstructive uropathy is a very common problem we come across, and I thank consultants for suggesting this topic to talk, because I myself do not realize how common it is, how much we are just passing through this problem every day without we do treat, but without knowing without understanding the seriousness and significance of this problem. So I thought it is a good topic to discuss among you all. Before getting into it, what is obstructive uropathy? It is anything which blocks the urinary flow from kidney to its exit. That is called obstructive uropathy. And when this obstruction causes damage to the function of the kidney, anatomical and functional damage, that is called obstructive nephropathy. This obstructive uropathy can lead to obstructive nephropathy, which can ultimately renal failure. The renal failure may be a temporary renal failure or a permanent renal failure, and it is important to know how significant it is, how much it can affect day-to-day practice. Here is a patient, 44-year female, underwent vaginal hysterectomy and cystoscopy repair on September 13, 2022. The patient, the surgery went on well. On the third POD, the catheter was removed. The patient went home well without any problem. On 10th POD, she presented to gynecoscopy with the history of vomiting and urine leak. The gynecologist suspected vesicovaginal fistula or uterovaginal fistula and immediately subjected the patient for CT KLV with urogram. And here is the CT KLV picture. You can see the very much distended bladder. The bladder is so much distended. There is a contrast in the pararenal space around the kidney. A lot of urine leak is there. The creatinine was 6. Actually, it was done simultaneously. Before getting the creatinine value, the CT urogram was done. The CT report very well obviously there is a urinoma because of the retention bladder, urinary bladder retention. The pressure is transmitted to the kidney. There is a tubular backflow and urine leak. The problem seems to be bigger and it's a big disaster. But simple catheterization gave a big relief to the patient as well as to the surgeon. Within 24 hours, the creatinine has come to 0.4 milligram normalized, and the patient had a substitute dialysis. The intake was 8,000 ml, output was 12,500 ml, and the repeat ultrasound on 26th showed there is a complete resolution of the urinary. So, post-operative urinary retention can lead to such a disaster if not addressed on time. This is a lesson we learned in this patient. Here is another patient, a young male, presented with history of reduced urine output of 1 day and after pain and vomiting. CT KLV showed urinary stone from both sides. This side is a UPJ stone and this is a urinary stone. And the renal parameter showed renal failure. Creatinine is 1.54 and potassium was 7.9 everything. If potassium is normal, we would have taken for bilateral DGST and local with the support of the Stanley anesthetist. But since the patient was having high potassium, the dialysis, the hyperkalemia was corrected and then taken for the URSL. After the clearing the obstruction, the creatinine has come to normal. This is another patient, 26-year-old male, presented with urinary colic of 4 days and chronic pain on for 3 months, and renal functions were normal, and CT urogram was done. This patient showing a small stone of 6 mm size, RGPJ. And that without any symptom, it was there for a long time and caused a significant reduction in the parenchymal thickness. And this patient, we attempted a URS and the URS was failed because of the tight obstruction by the stone because the stone was there for a very long time. So we but I was not able to pass even the guide wire. So Dr. Sir attempted PCN and anti-grade digestative, that also failed. So we had to leave a nephrostomy tube, and the functional study was done after 2 weeks. From the nephrostomy, about 200 ml of urine was there. So DTP renal scan was done after 2 weeks. That showed the function of less than 10% and compared to the opposite side. So to give a chance, we did a BCNL, and with the BCNL we were able to establish a track, and we have placed a stent, and the patient discharged home with the stent. So simple small stone, the silent stones can cause loss of kidney function. So any patient, even a small stone, if we treat medically, we always ask the patient to come for review after 3 weeks or 4 weeks, and even if they are not symptomatic, we do an ultrasound and make sure that they passed out the stone. And because we have seen many silent small stones caused loss of kidney. So this is another patient for 41-year-old male, had a retroperitoneal sarcoma, treated with chemotherapy, and he presented with renal failure, and there was a retroperitoneal fibrosis post-chemotherapy reaction, caused obstruction to both the kidneys, and he had a right hypernephrosis and left hypernephrosis, and he did a stenting on the right side. Long dural silicon stent was placed, obstruction was relieved, but not able to place the stent on the left side, was totally occluded, and even URS was attempted, but the passage is totally closed, nothing could be done. But with one side stenting and other lip obstruction, the renal failure will become, renal function has become normal. So these are the classical examples of obstructive uropathy, where the interventions can save the kidneys if it is not done on time. These things, I think Dr. Madhu has enlightened a few words about the obstructive uropathy, the causes, and as I mentioned, the causes may be luminal, extraluminal, or intraluminal. Intraluminal causes are stones, and we do come across very commonly diabetic patients presenting with renal fever and sepsis, where the scapula comes and blocks the ureter, and they will have a sugar infection and renal failure. In those patients, good stenting will be helpful. Even the blood clots of patients with HUDA blood clot can cause obstructive uropathy. Extraluminal causes, as we were telling, retroperitoneal sarcoma, retroperitoneal tumors, and radiation, fibrosis, and congenital causes. These are all and more importantly, below the bladder, see a prostate or enlarged prostate can cause obstruction and cause increase the intraluminal pressure and can cause renal failure. And post-operative urinary retention, I have mentioned one classical example. So how the pathophysiology is, when there is a blockage in the urinary tract that increases the pressure in the renal pelvis, leads to dilatation of renal calyces and the pelvis, and it causes the constant pressure atrophy of the renal parenchyma and fibrosis will end up in loss of renal function. So if it is acute, it will lead to acute renal failure. If it is chronic, it will cause chronic damage, where the function will not be reversible. So history, physical examination, all these things are like any other patient. So we still report line pain and fever and kidney stones. Any patient with a urinary stone or urinary polyp should not do NSAIDs without assessing the renal function. Always kidney safer analgesics better for the kidney, because this patient may have a bilateral urinary stone, or this patient may have a solitary kidney and urinary factors on one side, his renal function will be deranged. So imaging, ultrasound is the basic one, and then the CT, MRI will help us give us the exact cause of the diagnosis, and these are very accurate advice. So any obstructive uropathy, the first line of treatment is relieve the obstruction. It is in the form of a surgical intervention. If it is the patient is stable, then we can attempt a permanent cure, like in case of stone cirrhosis or stone removal. And if the patient is not stable, sepsis and high urea and creatinine, temporary measures are tried to relieve the obstruction and relieve the crisis, like stenting, and or if stenting is not possible, we can go for a laparostomy. And if antegrade stenting is not possible, we can do a percutaneous antegrade stenting scan. Dr. Muthurajan helps in antegrade stenting for us because it is conveniently done in the cath lab. And for the permanent patient with unilateral obstructions, obstructive uropathy is due to PEG obstruction or retrocavitatus, pyeloplasty, and uterostomies. And prostate surgery for patient with BPH with bladder outlet obstruction and the renal failure. In these patients or the indications for surgery, any patient with BPH with renal failure, the catheter has to be placed. The kidney function, once the kidney function resumes its normal, there is no question of medical management. This patient surgery is a choice. And in whom below the bladder there is an obstruction due to urethral stricture or CA prostate, where we are not able to place a catheter, then suprapubic cystectomy will be handy. And very rare or very unlikely we go for a conservative management in very selected scenarios. Patients who are all had a recent cardiac issues on double antiplatelets, and then those patients whose the creatinine is in the borderline, not very high or not like 30. In those patients, we may wait for 1 or 2 days. Even in those patients, if the creatinine is going up, if they are going for a sepsis, then we have to take this and we have to go for a intervention. And the simple, I already mentioned, catheterization. So, even the obstruction is not relieved, it will lead to acute or chronic renal failure. The stagnant will get infected and the patient will end up in sepsis. And more importantly, I like to highlight here is the bladder outlet obstruction. If it is not addressed on time, the bladder will go for a gradual distension, and the capacity of the bladder normally around 300 to 400 ml. When the residual urine is gradually accumulating more than 700 ml, 800 ml, the bladder will lose its contracting capacity, and these patients will not be able to regain its contracting capacity, and these patients will end up in having a lifelong indwelling urinary catheter. So early diagnosis and intervention is very important in the outcome and of any problem, and it prevents long-term damage to the kidneys. Chronic obstructive uropathy, like I mentioned, the bladder is obstructed due to bladder outlet obstruction. The patients will need a long-term catheters. If the patient end up in chronic renal failure, will need medical management or they need dialysis. And if the even if the patient recovers, these patients needs regular monitoring with imaging and renal function to see whether they are having any other recurrence of the disease. So I like to emphasize here on post-obstructive dialysis, and once the obstruction is relieved, the excess water and the salt that is accumulated over a period of time will be suddenly gushed out of their body. So they will have a lot of polyuria, and these patients has to be closely monitored. Like in the first case, within 24 hours, this patient had an output of more than 10 liters, which we do see in post-renal transplant. So these patients has to be the fluid has to be replaced, and the electrolyte has to be monitored. This dialysis will resolve once the homeostasis is achieved. once the sort and water analysis is checked. And it is important when these patients are in the diabetic phase, you have to replace 2/3 of the previous hours output as the IV infusion has to be done. And this patient can end up in hypovolemic shock, hypovolemia, and other electrolyte complications. Take-home message: the obstructive uropathy is a serious condition that requires prompt diagnosis and intervention to prevent irreversible kidney damage. Early health intervention is safe for the kidneys, and I thank you all for your patience.
Thank you, sir. And before, while you take questions, I ask, Ganesh Prasad, load his slides. Sir, wonderful presentation. I have a question in the first case. So there is a post-surgical case, expected injury in the system, in the draining system, either in the ureter or below down. It was managed conservatively. What do you think happened? No, I'm asking you, what happened to that case?
It's a very classical post-operative urinary retention in this case.
But there was a contrast leak in the CT.
Yeah, because of the post-operative urinary retention, the bladder, the pressure in the bladder is high. That pressure transmitted to the kidneys. When the pressure is transmitted to the kidney, instead of the kidney is becoming hydronephrotic.
So there is a seepage of urine.
Yeah,
so
the dialysis will rupture. This is a common thing we do see even in acute ureteric stones.
But I saw contrast below the kidney, contrast leak below the kidney somewhere. You correct me if I'm wrong.
That is a bilateral formation rupture, and the urine leaks through the fornices into the perinephric space. That goes the perinephric space going up to the even below. Pararadial space it leaks. Seepage. This is even in acute ureteric stones. We do see urinoma.
No, there was possibly a urinothorax in this patient because there was a pleural effusion on the right side.
Yeah.
So right side, sir.
I do not know.
It was there.
There is a massive moderate pleural effusion was there. But all that.
So there was no surgical defect.
No surgical. No surgical.
No, sir. No, why I raise this question is because there was a contrast leak, significant contrast leak.
Yeah, there is no ureteric injury.
Okay.
It's reported, and also ureteric injury will not get relieved by.
No, that's very much acceptable.
Okay.
Because there is a contrast leak, there is a general tendency to think there is a leak, anatomic leak, in the presence of prior surgery.
Yeah. That is a thing. That is our duty to say there is no injury, and with the simple catheterization will relieve.
Okay, so it will invite such a question when the presentation is like this.
Yeah, I understand.
Thank you, sir. Any more questions? No questions. Madam, please. I was expecting. Because it related to. No, retention is okay, madam. Because there was a contrast leak, I was just asking. No, that's understood.
Actually,
Because
this patient was on catheter after the surgery. The catheter was removed after the 24 hours. So after that, this patient went home and he developed a gradual urinary retention. He presented with the urine leak, not abdominal pain or not passing urine, because he presented with the urine leak. And so there was she was passing urine between, but there is a urine leak also there. So the gynecologist suspected a uretrovaginal fistula or vesicovaginal fistula.
you had some questions? Dr. Murali, sir, ask some questions.
No, what is the cause of the retention? 1 week after surgery.
You remove catheter in the morning and send the patient in the afternoon, no? With without verifying whether the patient has passed urine or not. This happens many times. 1 week means it should be qualified, whether they passed it well or not. Small quantity of urine, they result in accumulation of more residual.
Any patient after the surgery, when the Foley catheter is removed, we always recommend to discharge the patient only after 24 hours. Even when the patient comes for Foley catheter removal and trial voiding BPH, we always ask the patient to come in the morning, and we want to observe them for minimum 8 to 12 hours. Because these patients will pass urine in the initial few hours, they will pass about 100 ml and 200 ml, but over a period of time, by the time in the evening or when they reach home, they will have a retention. It is important to observe for minimum 24 hours, then only we can say whether they are completely fine in the bladder or not. This is a very post-operative urinary retention is very common.
Thank you, sir, for a nice presentation. Over to Dr. Ganesh Prasad. Let us listen what is his present, future and the past on erectile dysfunction.
Respected senior consultants and my dear colleagues. So here we are to discuss about erectile dysfunction, what was there in the past and what we are doing in the present and what is there for the future. So before 4000 years in Egyptian papyrus there are clear-cut words about erectile dysfunction and treatment for erectile dysfunction. The Egyptians started using this particular flower. This flower is called as Egyptian lotus, Nymphia cerulea. But now we know that this contains apomorphine. And this apomorphine has its effect in the dopaminergic receptors which are present in the brain, D1, D2 receptors, and produces good erection. So this is from Egyptian past. Let's move on to Europe. In Europe, Hippocrates clearly says that there was episodes of erectile dysfunction in people who had long distance horse riding, and even now we can prove that very clearly. And he says concussions for the treatment of erectile dysfunction. And in our own place, Charaka Samhita, which was written in 200 BC, says the Hindus believed that impotence could also be of mental origin. So here the concept of psychological erectile dysfunction slowly came. We had an idea of psychological dysfunction, and he prescribes powders made of sesame. Sesame once again is a opium extract. It contains little apomorphine in it. Masha pulse, sali rice and saindavasa, all these along with sugarcane was used as a concoction for erectile dysfunction. In China, well ahead, even before 4500 years, there was a complete manual, the Yellow Emperor's Classic of Internal Medicine, that clearly describes about erectile dysfunction, and he used 22 ingredients that the emperor himself drank and mounted 1200 women achieved immortality. That was given in the textbook. Later, during the time of Renaissance, after 1453, in which Constantinople was captured by the Turks, so slowly people started coming to Italy. There were a lot of good minds in Italy, and anatomy started reviving after Renaissance. So in 1718, Ambroise Paré did extensive anatomical dissection and the penile anatomy and concept of erection came very good. Hunter said that there is spasm of the venous channels which flow back, and that is very important in causing erection to stay long. Very simple words about penile anatomy. Penis has 3 cylinders. There are 2 corpora cavernosa and 1 ischio cavernosa, and there is a covering called as tunica albuginea. This is a very tough layer. The tunica albuginea is a very tough covering. Let's see how it's useful. There are 3 main arteries. You have the internal pudendal artery which goes into the dorsal artery of penis, cavernosal artery and bulbourethral artery. So here in the flaccid state, nothing happens. Whereas in erect state, the tunica albuginea actually compresses the perforating veins called as emissary veins. So when the emissary veins are compressed, what happens is the inflow comes but there is no outflow. So the blood comes in, but there is no outflow, and slowly the penis gets enlarged and gets erected. So they play a very good role. That is how it looks in the erect state. So the tunica albuginea also plays a very important role in preventing erectile dysfunction. These are all the stages of erection. We have a latent tumescence, full erection, and finally the most important stage is the rigid erection stage. Slowly there is an initial, slow and a fast detumescence. The cavernosal nerves and the dorsal nerve of penis actually give the nervous supply. Very importantly, the most important nerves are the parasympathetic nerves, which arise from the on-off nucleus, which are present in the sacral region, S2, S3, S4. They are responsible for erection. So, parasympathetic nerves are the nerves of erection. Sympathetic nerves are the nerves of detumescence and ejaculation. There are supraspinal pathways or pathways which are present in the brain. Two important areas in hypothalamus. The median preoptic area has an ability to recognize a sexual partner, and a paraventricular nucleus, very important nucleus, but here the secretor is different. Here the action happens by means of oxytocin. So oxytocin acts there in the paraventricular nucleus, which is responsible for stimulating erection. And finally, let's come to the most important part, the molecular basis. Here the mantra is the nitric oxide. So nitric oxide should be there inside the endothelium for the erection to happen, and nitric oxide does magic by converting GTP into cyclic GMP. In turn, cyclic GMP produces vasodilatation of the cavernosal channels, blood flows inside, stays inside, produces erection. So this cyclic GMP is short-lived. It's been killed by phosphodiesterases. So now, if we take away the phosphodiesterases, cyclic GMP stays for long duration, erection sustains. So that is the principle in which we use phosphodiesterase inhibitors for erectile dysfunction. There are 11 families of phosphodiesterases. Phosphodiesterase type 5 is there in the penis. Type 6 is there in the retina, and type 3 is there in the back. And central neurotransmitters D1, D2 is also there. Apart from that, one more recently identified neurotransmitter is melanocortin 4 receptor. So the melanocortin 4 receptor is also, they have found that it is very important for erection. So what are all the reasons? We have arterial, neurological, hormonal and cavernosal reasons. It may be an organic or a problem with the penis, or there may be a problem with the mind. So mind related or it is organ related. How to differentiate these two types of erectile dysfunction? If the problem is going to be with the mind, the erectile dysfunction is acute. Yesterday the patient would have had a good erection, today there won't be any erection. Very importantly, it is situational. Only at times of certain times the patient has erectile dysfunction. At other times, for example, the early morning erections are really good and the patient has typical situational erectile dysfunction, whereas organic erectile dysfunction is very gradual. Slowly, initially it is grade 1 erectile dysfunction, third month it is grade 3, then it goes to grade 4, slowly it progresses. The reasons most of you know, atherosclerosis is a very important reason, and apart from that, neurological reasons like pelvic surgery, spinal cord injury and pelvic radiotherapy. We have the most important reason, the endocrine reason, diabetes. It produces both vascular erectile dysfunction and neurogenic erectile dysfunction. Of late, I am seeing a lot of youngsters coming with hyperlipidemia with erectile dysfunction. And finally, hormonal factors. And the reasons with substance abuse, both alcohol and smoking along with cannabis, everything can produce erectile dysfunction to a higher extent. Even in long distance cycle riders, there is some peroneal nerve injury which may produce erectile dysfunction. These are all the medications. There are a long list of medications which may produce erectile dysfunction. Most importantly, thiazide diuretics, antidepressants. So what we do here is, when these people don't respond to the medications, we take the people to vascular evolution, where we do a combined intracavernosal injection and stimulation. So here we inject the penis with papaverine. We give a very low dose, 0.1 ml of papaverine is injected into both the cavernosa. We do a scan before the injection. We do a Doppler study and see what is the peak systolic flow in the penis. And after injection, we do once again ultrasound Doppler to see what is the peak systolic flow. If the peak systolic flow is more than 25 centimeter per second, then that means that the arteries are really good. Okay. And along with that, we see a venous backflow. So for venous backflow, we look for a resistive index. And apart from that, one more sophisticated investigation is a nocturnal penile test. Here we use a buckling device which is applied to the tip of the penis to measure the resistance. And the name which is commonly used is a Regiscan. And that is how a Regiscan looks. The buckling device is applied both to the base and the tip of the penis. And every time erection happens during night time, this device will record the erection, the duration of erection, the intensity of erection, everything is measured. At least there should be 4 to 5 episodes of erection during a single sleep. Usually this is done under admission. This is how the interpretation or records are there. Hormonal testing is very important. Look for testosterone, FSH, LH. And sometimes prolactin may be the culprit. Hyperprolactinemia, especially in people with micro or macroadenoma, can produce erectile dysfunction. Now let's move on to drug therapy. What are all the medications which are used for erectile dysfunction? We have the oral agents, intracavernosal injections and intraurethral pellets. See, the discovery of oral agents was an accidental event. In early 1990s, they were testing sildenafil citrate for cardiac disease. They were testing it whether it has an increased endothelial capability of producing some changes in atherosclerosis, whether it increases the flow in the cardiac vessels. That was the test. It failed in the test, but it succeeded in producing good erections. So that's how sildenafil citrate came into use. Then after sildenafil citrate, tadalafil came into use, vadenafil, avanafil, udinafil. There are umpty number of medications. Now let me put everything in a very, very short capsule because of less time. So the duration of action is fastest with, the duration of action is very, very early with avanafil. Within 15 minutes after taking the medication, the action starts with avanafil. The duration of action is prolonged and it lasts for long duration, more than 36 hours with tadalafil. So tadalafil is extremely useful and it's given a name called weekender drug. So that is the use of tadalafil. Sildenafil is a very old drug. It has lot of complications, lot of side effects. So now the preferred medications are usually avanafil and tadalafil. Sildenafil can produce abnormal vision disturbances. I told you there are PDE5 receptors present in the retina also. It acts in the retina and produces halo. Blue halos are seen. Tadalafil has a very peculiar side effect. It produces back pain, severe low back pain. Sometimes the patient may have severe myalgia associated with tadalafil, which will presume us to stop the medication. Very, very rare complication, but a dangerous complication with these medication is non-arthritic ischemic optic neuropathy. One morning they will wake up and they will find that one eye is completely blind. So it may produce blindness of vision, and it's common in people more than 50 years, not in younger patients. Sometimes this may happen. The contraindications for PDE5 inhibitors are unstable angina, grade 2 heart failure. All these happen within past 3 months. If there is going to be uncontrolled arrhythmia or severe hypotension, all these are contraindications. See, other more important contraindications of the patient has RP, retinitis pigmentosa, never prescribe these medications. Somebody is going to have sickle cell anemia, leukemia, there is a high chance of going for priapism, which is persistent erection. So these drugs should not be prescribed in sickle cell anemia and leukemia. We now use daily dosage of PDE5 inhibitors. Instead of giving at the time of use, we actually increase the endothelial nitric oxide by giving daily dosage for continuously 3 to 6 months. This produces better effect. Apomorphine is one more drug which is also being used, which has its action in dopaminergic receptors in the brain. It produces erection in about 70% of people, but stimulating dopamine sometimes will produce sleep. So apomorphine will produce good erections, but the patient may sleep ultimately. Then comes the intravascular or intracavernosal injection of vasoactive drugs. The medications which are commonly used are papaverine, which is very easily available, which is very cheap. Then we have phentolamine, which is an alpha-adrenergic antagonist. The third medication is a prostaglandin, PGE1 alprostatin. Papaverine has a very good effect. It has been tried in 70s and 80s itself. Papaverine is a very old medicine, but the problem with papaverine is it produces corporal fibrosis. Corpora cavernosa will go for severe fibrosis, that is seen in 20 to 30%. The second problem is very high chances of persistent erection. Persistent erection is called priapism. The erection may go on and on for 4 hours, 5 hours, which ultimately will lead to erectile dysfunction. But it is very stable at room temperature. It can be used by anybody. It can be used at room temperature. So how to bring down the side effects? For that, we use phentolamine. So phentolamine is alpha-adrenergic antagonist. We mix phentolamine and this particular medication, that is called a bimix. So papaverine with phentolamine is given in preloaded syringes to the patient. Patient can have it with him. So at times of need, at time of coitus, patient have a shot of injection. Just 0.1 ml in the right cavernosa and 0.1 ml in the left cavernosa and go for the action. In certain people who fail for bimix, we use a trimix. So trimix is a combination of these two medications along with the prostaglandin. But the problem with trimix is once you add prostaglandin, it has to be stored in the refrigerator. It should be always kept in the refrigerator and it is less stable. If intracavernous injection therapy, somebody feels that I have some hesitation in putting an injection, I am not okay for it, I can't put any injection in my penis, I'm afraid, then you can go for intraurethral therapy. So in intraurethral therapy, we use prostaglandin in a pellet form. Prostaglandin is given in a pellet form and we have an applicator, and these applicators are used to introduce it inside the pellets inside the urethra. From the urethra, the medication gets absorbed and it can be used very well. Finally, hormonal manipulation. If the testosterone level is low, we give testosterone injections. Usually we give it in a depot form, about 250 milligram once in 2 weeks. Why not oral testosterone tablets? Because it has a very high first pass metabolism and it's metabolized in the liver. If there is going to be a hyperprolactinemia, usually we refer to endocrinologists. Usually they start bromocriptine, or if there is going to be a macroadenoma, neurosurgery is done. If everything fails and finally these devices come into use, very handy devices, many times people find it very useful. After using the vacuum erection devices, the penis goes on for erection, and to sustain the erection, a rubber band is obtained at the root of the penis to sustain the erection. Many times the erection lasts for 20 to 30 minutes using the vacuum erection devices. The pros are it is easy on demand use and easily portable, but it is very expensive. Very important, it is not spontaneous. Every time while having coitus, the patient should sit and pump the device, which may be annoying for certain people. So, contraindications, people taking aspirin or warfarin should never use these devices, because there is a chance of hematoma formation in the penis. This is the algorithm. So initially we start with oral medications. If it fails, we will go on for intracavernous injections, and combination of intracavernous injection and oral, if it fails, vacuum erection devices, and finally we come to penile implant. Now let's play this as a summary. We have a prosthetic surgery. This prosthetic surgery uses prosthetic devices to be implanted inside the penis. We have 2 cavernosal cylinders. These cylinders will be implanted inside. There is a reservoir which will be having some amount of liquid into it, and there is a pump which is placed in the subdermal region beneath the skin in the scrotum. So every time the patient uses the pump and pumps, the penis goes on for erection. When the act is over, there is a small button in the pump which is pressed, and the penis goes on for detumescent stage. So these devices will mimic the natural erection in a very good way. Complications, it may produce infection, perforation, pump complication and inflation complications. Sometimes these are all the complications of the implants. The deformity is called SST, supersonic jet-like deformity. Since the cylinders are inserted only in the cavernosa, the glans penis is not erect many a times. So only the cavernosa has erection, the glans penis doesn't have erection. It will resemble the SST plane's nose tip. And if there is a discrepancy in the length of the cylinders, then it may produce problem like this. This is an MRI picture of the implant. And apart from that, vascular revascularization is tried by anastomoting with the inferior epigastric artery, but it is not that useful when compared to the implants. The future, we have gene therapy now, it's on research. They use Maxi-K gene transfer with a smooth muscle specific promoter, and they have found that it's having good effects. Maybe in another 5 to 10 years, gene therapy may come into use. This is very much used now. We use platelet-rich plasma, where we take the patient's own blood, we centrifuge the blood twice, take the platelet-rich plasma and inject it inside the penis on the right cavernosa and left cavernosa twice weekly for 6 weeks continuously. And they have found that this platelet-rich plasma increases the angiogenesis. The blood supply is good. The nitric oxide in the cavernosal vessels is really good, and it's really helpful in people who have failure of medications and intracavernosal injections. Stem cell therapy is also in research now. They have tested it in rats and level 1 in human beings. They have found that the rats which were completely denerved, they have removed the cavernosal nerves in the rats and they used stem cell therapy. They injected the myoepithelial stem cells into the penis of the rats and they have found that there were very good erections. In humans, they tried adipose stem cells. Adipose stem cells, they found that 70 to 80% of people had good erection with stem cell therapy. Maybe in another 5 years, stem cell therapy will also come into use. This is a very good device, low intensity shock wave therapy. This machine sends sound waves, low intensity sound waves, and these sound waves are found to increase the vascularity of the pineal cavernosa. The vascularity, the nitric oxide in the cavernosa, everything gets improved. We have to give twice a week, we have to keep the patient in our outpatient, give this particular therapy, and we have to continue for 6 to 8 continuous weeks. And the results are profound. We can easily see that in a cut section in the mice, they have found that the vascularity has really improved, and human beings also it has been in use for 4 to 5 years. In our hospital, we have asked for it, and most probably we will get in future. So that is summarizing everything. We begin with medication, oral tablets, phosphodiesterase inhibitors, then go to injection, intracavernosal injection therapy. If that too fails, we give vacuum erection device. If that too fails, we have shockwave lithotripsy, which we can use for these particular erectile dysfunction cases, and finally pineal processes. Everything fails, we do surgery and place a pineal implant, which we are having plans to start in our hospital. Thank you.
Thank you, sir. So we had a long marathon session today. So you have closing remarks. You should.
Urology as a specialty has evolved in the last 50, 60 years. It has become a separate specialty about 50 years back. And subsequently what has happened is urology has been split into multiple subspecialties. Now there are people practicing, urologists who are practicing only pediatric urology, only erectile dysfunction, only infertility, only neurourology, like that. It has been divided and it has become put together. All subspecialties is a very huge specialty now. And in male infertility, there are people who specialize themselves and call themselves as infertilologists. So there is the advance of urology now. Anything else?
Thank you, sir, for the nice presentation, and we thank all the very nice presenters today for having an academic quiz in the morning. Thank you all, and we'll meet in the next week.